think we can wrap this up, but I'll ask each of you, what are you most excited about, Chris, in CSPC and CRPC coming? We saw the press release about the PSMA addition trial, and and what's the most exciting next new drug in terms of radioligands or any others that you are excited about?
No, I think the PSMA addition, we anxiously await the data being presented, is very exciting for hormone-sensitive disease.
And we all were really great accruers to that trial, so it will be really exciting to see that. How about you?
I would like to see if the immune therapy or the PARP can move up front in the treatment.
So if, let's say, niraparib and gets approved, that you would be happy to get that going for your patients. Okay.
Well, I'm very excited already about all the options
we
have. When I didn't finish my training that long ago, but even maybe 10 years ago, we didn't have many options. So right now that we're discussing, what we can give, and so that is very exciting to me. I agree with Moshe that having a more targeted, personalized treatments to the patient, I think is the next thing. If we can do NGS or a liquid biopsy and try to be more precise oncology, in regards to what treatment the patient should get. That is what I'm looking forward. Maybe AI helping with that too.
But I like the P strategy.
The 3 Ps.
The 3 Ps, and prostate and pocket.
Anyone can use it. So I think we're not too far away from having 3 different triplets approved in the metastatic CSPC setting. I think the goal in that setting for me is to extend the duration and delay time to CRPC. And I think I do think that PSMA triple-based therapy will be available, that there will be a PARP-based therapy available, a docetaxel. We already have triplets with docetaxel. And then figuring out which patients, whether it's clinical features, I think it'll lean more towards molecular features, figuring out which patients should get which triplets, and which patients, maybe those with an SPOP mutation, should only get a doublet, and being able to personalize that upfront, which to me is the most important space, is what's most exciting about the next couple of years.
How about you, Brian?
Yeah, so I think the molecular profiling and how we specifically target more treatment to the specific mutations, because we're already doing that in a lot of other cancers, lung, breast, things like that. I'd also like to see more advances, which I think there's some stuff out there looking at antibody drug conjugates, because we now see, look at breast cancer and then HER2 and how it's really changed HER2-directed therapy. We have PSMA as a target, so antibody drug conjugates have really changed a lot of other cancers, and I think this is an area that will really help patients. This probably will be more in the castrate-resistant upfront, because we definitely need help in that setting.
And do you all think that in future, like de-escalation of therapy is something, because men's quality of life is really affected. You can throw more, but at the end of the day, do we need lifelong ADT if they're not going to recover their testosterone, for example? So what are your thoughts on trying to
de-escalate?
Escalate, right?
Yeah, right.
I think it should be looked at. We're doing it in other cancers. With anal cancer, we're de-escalating radiation because of toxicity. So, I think that's something, especially with ADT lifelong. The old data is really needed, because it's quite...
Especially if they are like PSA undetectable for a long time.
Or if they're on their 4th line of therapy, is ADT really doing anything at that point?
Right.
Like in prostate cancer now, radiation oncologists have de-escalated, right? They're using a very shorter, I don't know if they're using for everybody, but they are offering it to a lot of patients.
I think there are sort of opposing trials through cooperative groups looking at escalation, starting patients on ADT, novel hormonal agent, and then adding docetaxel for patients who don't meet a specific PSA nadir. And then on the flip side, there are de-escalation studies for patients who I don't remember if it's 18 or 24 months, have a PSA that naders below a specific level to actually take them off of therapy and monitor at that point.
Yeah, those are the trials that we need.
Right. So, and both will ultimately be important.
Right. What are your thoughts on, not related to this, but I think about it a lot, like the GLP-1 drugs for our prostate cancer patients with all these, weight gain issues, and because I think there's more to the drug besides that, you know. I have actually recommended to a lot of my obese patients who I feel like they're gonna die of a heart attack and not prostate cancer if like their BMI is so high. So do you think that would be something like, you know, a lot of patients have these body image issues on the hormone therapy?
I mean,
And-
they have weight gain. I mean, it's
Yeah.
30, 40, 50 pounds after they've been on it for a few years. So,
Yeah.
I mean, it's definitely something to look into.
Yeah, I get a lot of questions from endocrine weight management because I send them to them,
Yeah.
and then they ask me
Oh, so you're
if I'm
sending them
okay.
for weight
I'm sending them
management. Nice.
before and also for breast cancer patients on hormonal treatment. And then they ask me, I mean, is the patient eligible? And as long as the patient is stable, I'm okay. I mean, there are another side of side effects that we have to be, you know,
Yeah.
like nausea, the vomiting, I don't know if the absorption of the pill will be compromised. If we're talking about PARP inhibitor with the medication, I think studies would be, you know, useful in that sense. But I am open to that as long as the patient tolerates it. I think I had a patient say, yeah, I'm doing great from, you know, my cancer, but I really want to lose weight. Yeah, that was the most important that was affecting her quality of life, you know. So
But I think also to remember that the number 1 and 2 causes of death in patients who have prostate cancer is the prostate cancer and cardiovascular disease.
Right.
Cardiovascular disease.
So I spoke to a company recently who produces some of these drugs, and as you can imagine, patients who have cancer were excluded from the trials.
Yeah.
But I think that we talk about the bone health and we talk about cardiovascular health, and I'm not aware of data to say that it's dangerous to give these agents to patients. And I think if it improves their cardiovascular risks, their risk of CKD, their general metabolic health,
Yeah.
especially
You know,
for
I have patients who are biking like 10 miles a day and they've gained 30. Like, there's only so much exercise one can do.
well, I had patients pass from a heart attack
Right.
Yeah.
and not from the prostate cancer. You know that.
Of course, yeah.
Well, no, but a patient that was very stable, and yeah, so it begins to wonder, you know, those
I
risks
think we
need to
should
be
do a clinical
tackled,
trial.
right?
I recently read that there's a generic GLP-1, so we may not have to deal with the companies.
Yeah, because now it's,
Focused on that right now.
it's like the forepit and the pockets, the regular pocket.
I think that's it for our discussion. Unless anyone has anything else, that was a great discussion. Thank you, everyone.